Retina Day session. So I'm inviting Dr. Kelkar first to start our IC. Dr. Aditya Kelkar, he is the director NIO Pune. No need to give any extra introduction. He is just an international figure. He is getting the International Hero Award for successive 4 years from ASRS. Buckland Award.
I must thank Dr. Maiti and Dr. Boral for this award, actually speaking, because it's because of them and of course Dr. Chirag that I started going to ASRS. Otherwise I was completely out of this ASRS gang. So when Dr. Boral gave me this responsibility of presenting my longest retina day, I realized I don't have a longest retina day, but I have many days which are very long. So I tried to select a couple of them. This is one lady, pseudophakic patient, underwent vitrectomy, silicone oil, tamponade, retinal detachment with multiple breaks. In post-operative follow-up, cystic subretinal fluid space filled was noted, retinal detachment PVR was noted, and so we decided to go back in and drain the silicone oil, encirclage, buckle for managing the anterior PVR. So first of all, because of the extensive anterior proliferations, we decided to place a 240 band. So the muscles are isolated. It's a standard way of dealing with a anterior PVR case. A scleral implant has been planned, so the scleral pockets are made, and then 240 band is used for the encirclage element. After that, we started removing the silicone oil, and then fluid air exchange was done. We stained these membranes and extensive proliferation was noted, and this was carefully removed. So here we are taking care of the anterior proliferations, and extensive retinectomy was also required. So diathermy followed by retinectomy has been done. And as you can see, silicone oil globule starts to pop out of that area. Now my silicone oil cannula cannot reach there. So obviously the cutter was taking too long to remove it. So ultimately that area was drained. Then I put back PFCL so that to allow more silicone oil to come up anteriorly. You can see there are extensive proliferation subretinal bands too. So as I put in PFCL, some more silicone oil escapes out from the retinectomy site, which was then removed. And then I reduced the height of the PFCL bubble because now there is a subretinal band which I want to remove. So I did a small drainage retinotomy, and silicone oil and a subretinal band was removed from the subretinal space. You can see another bubble of silicone oil now just under the retina. So once this subretinal band was taken care of, the silicone oil globule was again removed from the same area. It gets really difficult because the silicone oil removal cannula doesn't reach that far, and our 25 gauge vitrectomy cutter is too small to aspirate the silicone oil from subretinal space. But that was the only option, but at least it can create a kind of drag to pull this silicone oil out. So it's like a cyst. Maybe sometimes you can correlate it with a cysticercosis cyst, the way it comes out. So I initiate the vacuum and at least bring the silicone oil out of that retinectomy area first. And it actually makes your day extremely long because, as you know, this silicone oil is so stubborn, it doesn't come out so easily from that space. So after that, endolaser has been done, and then we reintroduce the silicone oil after all the silicone oil under the retina has been aspirated. So PFCL is removed, the fluid exchange done, and then the silicone oil was injected. This is the post-op picture, at least the central area still looks attached. Now this is another interesting story where we have a dislocated capsular bag complex along with the intraocular lens, and we decide to bring it out, and we believed that it will be a routine straightforward situation. So PFCL is put behind the lens, and then this bag complex is held with the help of forceps. I've already made a scleral tunnel, so I thought it's going to be straightforward. But here my forceps get entangled with something, and now I cannot even leave the lens out. So I unintentionally drag the capsular tension ring from the side port, and the intraocular lens is now in the middle. So I leave that alone and bring the IOL bag complex out. But as I realized that it's not a complete ring, on the lower side it appears to be complete, and thankfully I had the PFCL behind. So I could go back and check, removed the PFCL, and also removed this segment of capsular tension ring which was left behind. So when you remove the capsular bag complex, be careful to make sure that all pieces are out and some inadvertent rupture hasn't happened. And this was then followed by secondary implant of my choice is the iris claw IOL. So the complications are unintentional obviously and inevitable, but at the same time because of the nature of the surgery. However, a prompt recognition and management can significantly impact the post-operative prognosis. Thank you again. Thank you.
Thank you, Aditya. Nice talks. But my question was on first case, like in your subretinal silicone oil. What was the there was the rationality of silicone oil migration of silicone oil into the subretinal space? It was the undue traction. So whether the traction was present before and it was a new traction.
Yeah. So this
because
was
you have already settled the retina during the surgery.
Correct.
So that means the traction was not there.
That's
Maybe
correct.
you have done the all kind of good vitreous base excision, all kind of ear removal, memory training. But again, when you saw the patient post-operative period gradually.
So the patient had come back with a PVR.
PVR.
And
Okay.
with that, maybe multiple breaks and silicone oil probably was already emulsifying.
The
Probably must have
new
gone
traction. Yes.
One short, wonderful videos as usual. I think have pictures. Did the silicone same because we are in the topic of the second ठीक था. Did he have a pre-existing nasal break through which you enter, or you made a retinotomy?
No, I first made a retinectomy nasally to remove the silicone oil from that area.
Peripheral retina?
Peripheral. And then there was a subretinal band on the temporal side, which I was anyway going to pull it out. And through the same opening, I removed the silicone oil.
And most important thing, you have to remove the subretinal silicone oil not under air, always in the fluid
That's
condition. And also better to inject PFCL what you have given.
Yes.
Just for the complete removal of the subretinal silicone to migrate into
So
the
in his
vitreous cavity.
case, Aditya could not avoid the posterior, but Professor Klaus Eckert says the retinotomies have to be as peripheral as possible. Always.
All right. Thank you.
Thank you. Thank you, Aditya. Now I'm inviting Dr. Jayanta Goa because he has to catch the flight. So, Dr. Goa, please.
It's always.
He is the director, Sai Retina Foundation, and an international figure.
So can I have the So thanks Subhendu. Aniruddha, Devdulal, my heartthrobs from my city of birth. Nice to see Deepender here. And nice to be always, because I grew up here. Two institutions I owe my education, National Medical College and Don Bosco School, Park Circus. So, without much ado, the first case, there are three cases assortment. First case presented after re-surgeries in a case of a massive macular hole, maybe 3000 microns in diameter, with subretinal PVR, which we had to manage. And the second case, the duration lengthened long because of the incessant bleeding that occurred due to, you would see a Eels case, presumably Eels case. Eels is never a definitive diagnosis, so presumably Eels case with a mid-peripheral neovascularization, which we had great difficulty in tackling and stopping the bleeding. It's very easy to tackle diabetic bleeds, on the contrary. But Eels, sometimes proliferations, because preoperatively you're not giving anti-VEGFs, so those bleedings are very difficult to control. And the way I isolated and then treated that area would be shown. And the third, last but not the least, case of a very old chronic traumatic macular hole in a case of a young girl, and for which we did a autologous retina transplant with very good results. So first case, that multiple surgeries, maybe 6 of them in a separate center, presented to us. And after dealing with the preretinal membranes, which took a lesser time, we had to pull on the, already 360 retinotomy was done in the previous case. So we just pulled on the retina and marked out with diathermy those areas and unfurled the retina and yeah. So we started dealing. This is a typical tug of war maneuver, which using a forceps and spatula in this case, which is extrapolated from the epiretinal tug of war fashioned by Dr. Cyrus Shroff long back. So this is the same tug of war method used subretinally. So this area was carved out for the autologous retina transplantation to cover the massive, very huge macular hole, almost 3000 micron in diameter, and placed. We put oil, of course. And this was one of the very early cases of ART that I attempted. Of course, we now have a big series of cases in various indications: myopic macular hole, detachments, traumatic macular, huge chronic macular holes, macular holes in BRVO, macular holes in diabetics. So, so peripheral retina does have good neuroretinal degenerative potentials, and thank you so much. And was placed and we got good results in this case. PFCL silicone exchange being done at the last part. This is the case of the peripheral fibrovascular neovascularization in the case of presumably Lee's disease. And after clearing the central vitreous, the location of the fibrovascular patch was such that it was incessantly and made it a long surgery, instantly coming down. So we were vacuum cleaning repeatedly up to the and then we decided to, while we were tackling the vitreous base, we decided to, I'm using depression and so that the area is highlighted. Sorry about the colors. So we isolated, because the main concept is to isolate that vitreous base, because we can't dissect. Because the banyan tree type thing is not those vascular epicenter type things you see in a diabetic. So very difficult to dissect. So you cryo that area also, add cryo. And in the second stage, I actually not shown here, I did a retinectomy in that area. And here's the last case, ART in a huge traumatic macular hole. This is a pre-op picture. And after the usual PVD induction. There was a dialysis also in this case, peripheral, which we lasered effectively we didn't have to buckle the dialysis. After ILM peeling, we choose a area superiorly, relatively avascular area, and harvest ART graft out of that. Here is by using a 41 gauge cannula, this is my technique. And initial cases, so I did a lot of diathermy. So much of diathermy is not necessary. Just you do a 4-marker diathermy and you fashion the roughly 1.5 times the size of the hole because of the latest possibility of shrinkage of the graft. And you would see the end result was very good. We did have, I collaborated with Rohan in RP Center for the microperimetry and some uvulous spots at the edges of the hole you would see when I show the microperimetry, and vision improved from hand movements to 624 now, and almost more than 2 years follow up. And the earlier cases, unnecessary, I put a drop of Helon just to, not necessary. And here I put gas, SF6 gas. So the initial days, the graft making took a long time. It was a post-op fundus photo, post-op early OCTs, and late edematous changes take place, as Hani Hamza also showed us, and Tamir have shown us. And these edema settles down over, it takes a long time to, you'll see, 332 days after. The edema is lessening down. This is the microperimetry, and some yellow spots are there at the edges. And thank you so much.
Dr. Guho, would you prefer to do the cautery around the graft before from the donor area?
As Rupak also showed in this series of cases, I already mentioned that I did too much cautery. But at the end, you would see synaptic, ectopic synaptogenesis also taking place in that graft, in spite of the cautery, as he also showed in his series of cases. But definitely just a 4-point cautery nowadays.
But in the retina and the mid-peripheral area, the vascularity is not that less. So if you take the graft from the periphery, the vascularity less, so you can, no need to do the cautery. But if you are doing it from the mid-periphery, you have to do some kind of cautery, but you can do it after taking the graft.
Mechanical advantage, you
Yes.
can't go too much to the periphery. So it's easier to, after that you'll have problem in placing
Yes,
the graft.
yes.
There is the lesser distance the graft has to travel, the lesser chance of the upside down turning of the graft.
So are you using PFCL during this procedure?
Yes.
Okay, thank you.
Thank you so much.
Thank you, Dr. Guho, for joining with us. So I will invite Dr. Aniruddha Maiti. Okay.
Thank you so much.
Best wishes for your happy journey. Thank you. Dr. Aniruddha Maiti is the director of Global Eye Hospital, and he will talk about few of his longest day cases.
Thank you, Dr. Boral, for giving me this opportunity. Well, in VR surgery, any surgery can go long hours, sometimes planned, sometimes it is not planned. So I will show 2 cases where the first case, it was a simple case of vitreous hemorrhage, and the second case is a traumatic case. So can we just play? So it was a dense vitreous hemorrhage. When we advised this patient, it was a subhyaloid hemorrhage, but the time this patient came, it was quite a dense hemorrhage, and you can see a well-defined sub-ILM bleeding behind this dense hemorrhage. So after doing the vitrectomy, taking out this organized blood, we plan to remove the ILM. Generally, these cases do pretty well. The vision improvement is also very good from the very next day itself. So I thought I will just peel the ILM, flush out the blood, do some peripheral dissection, check out the periphery and close it. So that was the plan. So just trimming the vitreous base, you can see there was a lot of hemorrhage. Now can you pause? Now something happened after I did this ILM peeling. This patient had a bout of cough and the patient literally sat on the table. And once the patient was again reinstated in the operative position, you can see through the cannula, obviously this cannula, although valved, it leaked, and this is the spot of blood came out. And can you play it again? Now this time the case became even more difficult. It was easier case before to start with. Now it landed up into suprachoroidal hemorrhage. There was a superior RD. Actually we had to pass the instrument through the suprachoroidal space, and the hemorrhage, you can see it again. Fresh hemorrhage is a little bit difficult to take off. So had a difficult time. It's in a video, edited video, but it took really long time to remove this fresh bleeding. And it was so difficult to introduce the instrument from that port where the suprachoroidal hemorrhage has happened. We had to go to the other side, other port, did the fluid air exchange, and with the other side of the other port we had to complete the laser. But doing the laser also, we had certain areas was beyond, we could not do laser, so did some cryo. So ultimately, which was a simple case, land up into a long day, and in the end it went well. The vision improved to 612. Now this I had expected that this trauma cases are full of surprises. This was an exploration, had an injury, a very typical injury, atypical injury I would say. The fan fell into the head as well and the side of the eye. And obviously the globe rupture, it was an exploration and we saw the globe rupture. And the globe rupture extended beyond the muscles. So we had to disinsert the rectus muscles, and then we could access this is the disinsertion process, and once we disinserted, we could access the rupture, which actually had a long extension. Now we can easily suture this part. Now this patient had a head injury, so the patient was actually in the hospital, in a multi-specialty hospital for 2 weeks. But in the ultrasonography, although it was very disorganized, but we could make out there is a detachment. So instead of a double stage procedure, we thought we will do, and a single stage operation, we cannot leave the RD for a long time. So once we remove the hyphae, we saw that the lens needs to be removed, otherwise it was difficult to, the visibility was extremely poor, there was detachment, there was vitreous hemorrhage, there was suprachoroidal as well as the choroidal rupture. So we decided to remove this lens, and at least we can access the posterior chamber easily. And this was a traumatic case. We had expected this is going to take long, so the patient was in general anesthesia. And otherwise, local anesthesia in this case it becomes very difficult. So once we removed the lens, then put a AC maintenance, because I mentioned that there was a suprachoroidal hemorrhage as well. Now it was all mixed up, blurred retina. So with a lot of patience, first step by step remove the bleeding. You can see the underlying, that's the choroidal rupture. choroidal rupture area. Now, once the hemorrhage, once it was removed, we could make out the extent of detachment. And very carefully trim the blood. Now put PFCL. So once the posterior pole is stabilized, we can actually work on the periphery. 1 minute. Now we can see the disc and the vessel posterior pole become little bit clean. We could not do the subchoroidal drainage because we had just repaired the wound and the eye was hypotonous. It was difficult, and you can see we could do the laser and then did a silicon oil PFCL direct exchange. That's the last bubble of the PFCL. Ultimately, this patient did pretty well actually, and I'm very happy because he has also lost hope because he thought that it's gone. This is a very bad injury, and ultimately, from perception of light, this patient turned out to be 624. So this was two different cases with a lot of patients, and obviously due to this good viewing system, we can manage these cases and give a good prognosis. Thank you.
Excellent presentation. Dr. Devdulal, in question.
One thing is, like for the, when you did this under GA, general anesthesia, so do you give a little bit of a local anesthesia also in this? You
So
asked
this
the
was
anesthetist.
this was an open wound.
Yeah, that's why I asked. So difficult.
No,
So you had any, because the patient was under in a hospital, and I hope there were no cardiac issues. So for the, because you did muscle disinsertion also.
No, we didn't give actually because the fact we didn't give is it was all messed up,
Obviously, yeah.
and it was an open wound.
Yeah.
So
Yeah. So
It's
I was
hypotonus
just
eye,
wondering, like after you had done half of the, just for like my sake I'm asking, after you had done half of the suturing, would it can we in certain situations can we do a, this is a question to all, some subtenon injection for in this kind of
that
situations?
can be a subtenon could
We
have
can
been
we
given.
can do, no?
Could have been given, yeah.
No, basically, you have to be very ready with all kind of like situation, like you have to remove the cataract, and anyway
it was
timing
like
is-
doing all surgeries,
yes,
squint and cataract.
just to make more maneuver intracollarly. Yes, Dr. Reddy.
Dr. Mathi, the first case that you said where almost you completed the
Yeah,
surgery,
yeah.
ILM Valsalva maneuver, ILM peeling was done, and
Yeah.
then the patient became uncooperative. And
Yeah,
then this-
patient was during the ILM peeling also started coughing.
But I think the first thing was suprachoroidal hemorrhage in that
Yeah,
patient.
yeah. Suprachoroidal hemorrhage happened, and actually we didn't know what is there inside when he went
again.
inside for the second time, and I had to push my instrument inside, and then the RD actually that was an iatrogenic. So it was like iatrogenic on part of the doctor as well as for the patient.
If that RD had not developed, you could have just closed the case,
Right,
I guess.
right.
Yes.
No, the hemorrhage, the fresh hemorrhage also was there, and which settled in the posterior pole.
So where was the break? Is the disinsertion of the
There was the
Direct.
break. RD was there near the insertion instrument. It was
okay.
instrument induced.
Okay, thank you.
Just
Thank
one
you.
question. What if in case the patient had developed suprachoroidal hemorrhage and you had closed the surgery and maybe deal with it subsequently 2 weeks down the line? Would that be...
But it was not that extensive. It was
To begin with,
more
it
of
didn't look
basically
that
I
bad.
didn't know what has happened inside. I realized when I went inside and there was suprachoroidal and I induced a detachment as well. So I had to repair the detachment and take out the blood.
But I think the courage on your part to operate on a patient who's already sitting up literally coughing vigorously to finish the surgery with all this is
I had to
creditable.
You have to complete. Okay. Okay, so our next speaker is Dr. Devdulal Chakraborty. Share your longest days. Dr. Devdulal Chakraborty is the head of the department Retina service in our Shadow Police Center, Disha Hospital.
Thank you, Dr. Boral, and this is something that I share with him because we work in Disha hospitals, and we actually have OT days in common with Dr. Samar Basak, who happens to be the AIOS president, and he's also our cornea boss and one of our directors. So this is regarding SFIOL and corneal opacities. So these are much speeded up surgeries, no financial interest, of course. So this is the first one is SFIOL in moderate corneal opacity. So for any surgery, what is essential is the ability to see what you are doing. But if you cannot see what you are doing, then you are in real soup. And both of us have long days for these kind of surgeries. But at the end of the day, both of us are happy that we could maybe help chip in our bit. So this was a 61-year-old gentleman post cataract surgery elsewhere 1 year back. With a ACIOL and presented with corneal opacity and was slated for a 2-stage surgery, initially seen by Dr. Basak himself. Generally what he prescribes is that we do the first stage surgery with IOL removal and SFIOL, and then he goes and does the EK, maybe DMAC or DSEC. So let's look at this. I have actually removed the epithelium to facilitate a little bit of make a little bit of clarity for me. So once the epithelium is removed, we mark and do the usual peritomies. And as you can see, these are really speeded up surgeries. This is a surgery that took me around 50 minutes as opposed to a normal SFIOL time of maybe 20-25 minutes. So you can see initially I'm looking into to find out if there's any gross thing that's visible inside in the posterior segment. So we open up and we try to manipulate the ACIOL. So this part is the easy part. Usually this is the easy part, as you will see slightly differently in the next case. And we are able to manipulate this ACIOL for once without any hyphema or anything, and we take it out. And in the process we break the haptic and we retrieve it. It's there in the wound only, and then we go in and do a little bit of anterior vitrectomy, and then I check whether there's any posterior segment pathology. Looks fairly good only, and then I enter for the make the entries for the forceps. And this is the trickiest part. If you notice here, this it has gone back. So the trickiest part is to actually hold the haptices of the we use Acrisoft multi-piece IOLs, and so that is the most tricky part to sort of do, because you cannot really see in this kind of corneal opacity. And this was one of the cases where there was lesser corneal opacity. As you can see, it's very difficult to grasp this and take it out. So thankfully after a lot of attempts at visualization, it came out, and then the other side also, the haptics came out, and what I generally do is I just tuck in the ends into a tunnel and leave the rest as it is, and then finish it off with glue. So this is kind of the end of the surgery, and happy for me. And the next part was actually the one that brought in the smile to the patient. The patient underwent DMAC by Dr. Basak, and had 6/9 partial vision after 1.5 months. So that was something also with little bit of pupilloplasty that he did. So this was really awesome for the patient. Now the next one is a patient who was one-eyed, had lost another eye to an endophthalmitis, and again the same advice: vitrectomy with IOL removal with SFIOL, and the next stage would be a DMAC or maybe a DSEC. So this was the kind of corneal opacity that we started off with, and this is a surgery that actually took close to 1 hour 40 minutes. So even after removal of the epithelium, It's not really very nicely visible, but anyway, we went in, and as we went in, we saw that there was something on the cornea. There was this whole layer. So, we initially did a little bit of anterior vitrectomy, and then we tried to manipulate the ACIOL, and this was, something, this was stuck. So basically, what had happened was, this part, there was a PI that was done by the previous surgeon, and one of the haptices had gone inside through the PI. So we had great difficulty, lot of time we spent, and the cornea was folding up. This part actually was folding up, and we had to do repeated viscoelastic injections, and finally we got hold of one haptic, and we couldn't remove the IOL in toto. So what we did was we had to cut one of the haptices and remove whatever was available, and then we went in. We thought we could pull this out. You can see there's a PI there, and it had gone in through the PI, and even then we couldn't manipulate it. So finally I thought, okay, let's cut it off again, and we cut it into two pieces and brought one part out, and then using a bimanual technique, using a dialer and a McPherson's forceps, we finally could get it out. So this was really tiresome, and we were just hoping and praying that we could finish the surgery. And then I thought, okay, let me bring my 26 gauge cannula needle to get this out. The first one came out easily, and we thought that we will put in a same 26 gauge needle, bring it right up to this part, as you will see here, so that at least we don't have problem visualizing how to put in the haptic. This part went well, but maybe I was too hasty, and the needle came out but the haptic did not come out. So we were back to the usual handshake technique of sorts, and went in with 2 forceps, and this was again very tough. Probably spent around 15-20 minutes trying to figure out where the haptics was. Ultimately a bent haptic came out, and finally we straightened it up and inserted the two into the tunnels, and ended up the surgery. So this he has actually just done a DSEC for this patient, and patient has 6/24 partial vision. So this is also something that is great for the patient. So together we can make a difference. Thank you so much.
Thank you, Dr. Devdulal. Basically, what is your experience if you keep in retro illumination mode of the microscope, so that you're grasping the second optic or the first optic will be easier? Even in presence of
Sometimes I
corneal
use,
opacity?
sometimes I do use the retro illumination. Sometimes I even use the chandelier.
Yes.
But like it is sometimes nothing works, and in very bad corneal opacities it's very difficult to sort of especially
you can use intracameral illuminator by the assistant, so that or through the pars plana, if your assistant is smart enough, he can just hold
that is what we use.
Little bit,
Chandelier
so that
sometimes.
Yes.
Chandelier that helps.
Or that routine illuminator in the anterior chamber.
Right.
Yeah.
Yes.
You can insert chandelier at the limbus itself.
Yes.
And do a PI in that area where cornea is clear, and you can do your manipulation in that area.
PI in the sense?
A good large surgical PI, peripheral iridectomy,
For?
to visualize things.
No, this is
The area where you don't have corneal opacity.
no. Usually these are like the PI is not an issue, because with
PI, what happens is then that gives you a window to visualize posterior segment and repair detachment. If you are operating,
I get your point, but really haven't had the necessity to do a PI, large PI, primarily because these patients will be undergoing a DSEC or a DMAC, so he will be putting in gas. So as much of the pupil, like the iris is spared, is good for the corneal surgeon.
Dr. Devil,
Yeah.
since you share OT with Dr. Sammak on the same day, the first case at least I think combined both could have been on the same day. I mean, it was not a,
I think I have very poor knowledge of cornea. I have poor, I'm
not you.
yeah,
You and
yeah.
Sammak together. You
yeah,
could have
yeah.
done on the same day rather than.
But that you cannot do a DMAC and a SFIOL on the same day. I think that would
I
be a
think
difficult
it was
proposition.
done once I had such a case. I mean, I don't do it, but the cornea guy who's handling the case, he's capable of doing a.
We've actually done PK with with like vitreoretinal surgeries, but PK as in like you with a sort of
One of a
normal
case, not
PK,
I don't do the
not EK.
Basically, Dr.
Yeah.
Devdulan and myself, both of us are doing simultaneously on Dr. Boshak's case in all PBKs or ABKs cases. But the thing is, if you do it on the same day, basically you don't know what would be the stabilization of this IUL. If the IUL is stable enough for next
You're
2
worried
to
about
3 weeks.
stimulation on this first
No,
day.
okay, I know it is stable. So SFIL is very much stable. If you injure the patient on table also, it will never dislocate. But if it is perfectly inside the intrascleral tunnel, fitted into the intrascleral tunnel, but still due to the further not to aggravate the inflammation or other things, because the preoperative counseling, it is very important, and preoperative making the importance of the understanding, like what is the situation, and you have to go for the two-stage surgery will definitely give you the maximum result. That's
Because I had once a thing like this, vitrectomized eye, the scleral fixated and this corneal decompensation. The
Yes.
cornea guy who's handling is also capable of doing a scleral fixated, so he did it himself, both.
Right.
So
But you cannot do the vitreous base section, PVD induction, cornea guys.
He doesn't like it.
Okay.
He doesn't like it. So you have to listen to the president, right?
Okay, so thank you. So Dr. Raji Rama Reddy, I'm inviting him to share his longest days.
Yeah, thank you, Dr. Subhendu. So I'll be sharing some of my 3 longest cases. Retina. Yeah, time is actually relative, the length. When you say longest cases, when you're operating, when you're doing your own unplanned complications of yours, every moment seems to be very long, drudging. So it is so these are the 3 cases where the actual duration may not be very long, but I really felt each moment was pretty long. First case is a globe perforation, then an expulsive hemorrhage, both in a macular hole case, and then an unusual blood clot. So this is a macular hole case, full thickness macular hole. This patient was taken up for surgery. The anesthesiologist said that he had a problem while injecting, and there was a lot of resistance. And I saw that probably he has done a globe perforation. I repeated the block and then went ahead with the surgery. Yeah, this is how the surgery looks. You can see there was a slightly perforation near the vascular arcade, and then a little bit one more perforation slightly at the equator region along the needle track. So as planned, PVD induction was planned, and then along the lines of a routine macular hole surgery. After the induction, you can see clearly the extent of the retinal defect at the posterior near the vascular arcades. And you also see that there is a peripheral small retinal detachment to the tear that is there in the periphery. So basically the needle, whatever is done, is there injured at 3 places: periphery, equator, and the posterior pole. So it is all RD developed that intraoperatively was limited inferiorly. And so that is so vitreous base dissection was done with indentation in this particular case. Then of course some endolaser was done along for the 2 breaks near the arcades and the equator. There's one more that's there, the periphery, that I plan to do under gas once it's settling the RD. So the inverted ILM peeling was done for this case. And then fluid gas exchange. You can see that the other break in the extreme retinal periphery. After fluid gas exchange, flattening that area. Some more endolaser was done. And this is a break that is there that needs to be lasered under air. C3F8 gas was injected in this particular case because we didn't want to unnecessarily surprise the patient with some oil injection and then removal. Yeah. Yeah, this is how it looked on the first post-operative day. And then this is also on through gas, the macular hole had closed and the patient did finally well after all this. The other case is of a 65-year-old lady, diminished vision is 3 months. She has been planned for a combined cataract and macular hole surgery that was done five years back. So, yeah, there was an Ingenuity demo that was going on while I was doing the surgery 4 years back. Cataract surgery was uneventful, and suddenly PVD induction was done. After the induction of the PVD is when we notice a this is when the start. There is a see that there is a mound in the inferior temporal quadrant. It did appear grayish. I was thinking it could be a retinal detachment, and I was trying to look for a causative break. As I was indenting and looking for a causative break, it was further increasing in the size, and injected PFCL to flatten the retina, thinking it was retinal detachment, but it was along with even with the PFCL, the mound which is increasing. That's when I realized it is not retinal detachment that we are dealing with, and it's an probably expulsive hemorrhage. So it was closed at this stage with the PFCL inside. You can see the choroidal mounts kissing behind the lens. Yeah. He was taken up for resurgery after 2 weeks, this particular patient, and the remaining PFCL we did do a 20 gauge ports just to see if there is any other residual choroidal fluid that will drain through this. The residual PFCL that was there in the posterior pole was removed. Inverted ILM peeling again was done for this case. Once again, retinal periphery was inspected to see whether there is any retinal detachment. Media was slightly hazy, but we could achieve inverted ILM peeling. And then the case was closed with gas, SF6 gas. Yeah. Patient ultimately did well in this case. We have a 4-year follow-up. Vision improved to 20/40. And this is of course last case where we find this hypertensive patient with a vitreous hemorrhage that you see mostly inferiorly. Somebody else has diagnosed it could be branch retinal vein occlusion. And then he was taken up for surgery. You could see that there were layered vitreous hemorrhage, and so PVD was induced in the rest of the quadrants, but you see there is one localized hemorrhage in the inferior quadrant that was very densely adhered to the underlying retina. We don't know. As soon as we tried to induce that detachment, induce the PVD from there, we found that the retina underneath was tearing up. You can see there that the retina was started lifting it up. It's a very unusual, strongly adhered blood clot. So PFCL was injected this stage to probably help in, and under air the anterior extent of the vitreous blood clot was removed, and probably retina was detached at the anterior extent, and retinal breaks were created in the extreme periphery while cutting the anterior vitreous. This is all being done under air, just to have a better view, and any bleeding that's happening you can still have a good view. And this is under fluid now. You can see that the anterior breaks are there, but this blood clot that is very densely adhered to the retina was difficult to remove. You can see the ghost vessels behind, suggesting the BRV was the diagnosis. At this stage, we could only have to think of doing some sort of a bimanual maneuver. I thought it's too difficult to grasp at this blood clot, so retinectomy was planned for that area where that is densely adhered, and the clot and the retina along with it. Retina had to be sacrificed to safely complete the case. This was followed by a fluid gas exchange and silicone oil in this particular case. This is how it took first post-operative. Thank you. Post-surgery, we did have to access the ultrasound in this space. We find that it was pretty localized hemorrhage inferiorly that is very strongly adhered to the retina. With yeah, that's it. Thank you.
In your last case, what was the reason for a strong attachment? Was it a polyp or
It's not.
angioma?
It's base case of BRVO. When you lift the hemorrhage, you can see there's a
Polyp
ghost
was
vision.
there.
No polyp. It's basically branched retinal vein occlusion. with
Occlusion,
is
but a lot of attachment was there
yes, probably
from the NVs.
from the NV. Basically, a large
multiple
NV
NVs,
with
yes.
kind of a detachment. We do.
So you have to avoid undue traction while doing the peripheral, and you're very careful within the peripheral attachments also. And what was the your after how long you did this in your expulsive case? How long? You
2 weeks.
did?
2 weeks.
After 2 weeks.
2 weeks we did the research.
After that, all the expulsive
All
has
the-
subsided.
Surprisingly, we did not know the composition of that because after 5 days, when we see the choroidals was mostly it did resolve. The choroidals were resolved. So I did think it was not suprachoroidal hemorrhage. It could be a choroidal detachment that progressed so much, and not a
Yes,
hemorrhage. per
because
se.
when you took up the patient for the resurgery, the retina was absolutely
yeah.
looking healthy,
Healthy.
just like
Yeah.
primary cases.
So but with the closed valves, I was wondering how is a choroidal detachment possible? There was nothing else. It's 68.
Thank you, Dr. Reddy.
Thank you, Dr. Subhendu.
Yes, Dr. Dipender, please.
Challenge we sometimes see is if it is massive,
You can use.
massive suprachoroidal hemorrhage, kissing choroidal and with its hemorrhagic choroidals. Now challenge is if you wait for 2 weeks, the damage to optic nerve head due to
Much
stretching of vessels is too bad, and the damage is much more than what high IOP would lead. So now off late in couple of cases what I did was I went inside after 1 week itself
Yes.
and did partial drainage, and you realize it will not completely drain at 1 week, but at least 20-30% will drain, and that kissing choroidal goes down. And I tell these patients will come back again after another week, so at least their pressure comes down and they don't go into PL negative. So massive ones you can go for 2-staged intervention also, because
So-
sometimes you keep on waiting and then iridocorneal contact and they are so bad. By the time blood gets completely liquefied, eye is gone.
Yes, so the take home should be before 7 days, you should not intervene. And the best time is 7 to 14 days. Yes. Dr. Baiva? Yes. Yes, so I am inviting Dr. Shovik Da to share his longest days, and he is our VR consultant in our Disha Hospital. Dr. Shovik, please.
Hello everyone. Hope you all are enjoying this session. Thank you, Dr. Subhendu Boral sir, for giving me this opportunity. Here I am going to share you 3 of my challenging cases. Case number 1. It is a 70 years old male one-eyed pseudophakic patient present to my OPD with dimness of vision for last 6 months. Left eye, there is PR inaccurate in all quadrant, and left eye, and there is rhegmatogenous retinal detachment with PVR D2 changes. So first I removed the all membranes and traction from the disc and the macular area meticulously. Then PFCL was introduced to stabilize the posterior pole. Then I tried peripheral vitrectomy to detach all type of vitreous adhesions. Then epiretinal membrane was removed under the PFCL very gently. Then I did fluid gas exchange and tried to drain out the peripheral fluid. But here some accidental, sorry. But during the fluid air exchange, there is a sudden entrapment of the air into the peripheral retina. It is actually denote there is a marked intrinsic traction into the peripheral retina. So I decided to do for a 180-degree retinectomy, as the air entrapment is between 180-degree. After retinectomy, I did fluid air exchange and tried to drain out the fluid, but this time I was stuck with some another surprise. The free retina get rolled and flipped to the another side, and PFCL got slipped into the subretinal spaces. Actually, I underestimate the power of intrinsic traction, and that is why I did 180-degree of retinectomy. I have to do 360-degree now. But I tried to drain out the PFCL, but I was failed. I tried to manually drag the retina over its previous side, but I was failed. This time I realized there is infusion is off, and I on the infusion, and the retina is mobilized, and then I meticulously give PFCL in the right plane to stabilize the retina, and this is the that time I realized that there is a need for 360-degree RR, and I did the 360-degree RR at that time. PFCL subretinally was drained meticulously. Peripheral retina was trimmed. Then I injected more PFCL to flatten the retina. Continuous barrage laser was applied, first in continuous mode, then in repeat mode, to prevent iatrogenic tear in the latter phase. Then I did direct PFCL silicone oil exchange with 5,000 centistoke silicone oil, and I closed the cases. Post-op visual acuity after 3 weeks is 6/60, and after 3 months it is stable. Then can come to the case number 2. Here, a 70 years old male pseudophakic patient referred to my OPD for silicone oil removal and glue dial implantation in left eye. Previous history of GRT with traumatic subluxated lens was there, and he was managed efficiently by previous surgeon, and the best corrected visual acuity was 6/60 in the left eye. The retina is on under silicone oil, and there is a previous macular ERM is present. So I did the case with in the routine fashion. SFL marker, I did a scleral pocket in both sides. Then I opened the corneal incision. Is there a aphakic patient? I drained the silicone oils to the same wound with infusion line on. Then I meticulously removed the ERM from the retina. And I did a prophylactic barrage laser for safety. Then 180-degree apart 2 type of sclerotomy is introduced for extravasation of the haptics. But during the insertion of the SF5L, I was suddenly noticed that there is a large globular brownish mass actually just developed sub-incisional area, and I was totally stuck with that time what is happening. I just, sorry. And I was realized that it is actually that there is accidental slippage of the infusion line going to the subretinal, the fluid going to the subretinal space, and that kind of situation can occur in our surgery, and it is a very dangerous situation for a surgeon like me. And I actually withdraw the infusion line and fit it in the another line, and rise the intraocular pressure, just pray to the God the choroidal mass becomes settled, and hopefully and luckily I was escaped at this time, and all the fluid was drained. Rest of the procedure was uneventful. The haptics was extravased. And I check inside there is all okay, and I closed my case even applying glue. In the last case, the SFL was stable after 3 months post-op. The last case, there is a, in the next case, there is a 70 years old male, a 60 years old female patient. There is a dimness of vision for last 6 months with a best corrected visual acuity 6/60 and a history of PKP in left eye 13 years back. He is a corneal graft throat cavity and all sutures are removed and pseudophakic patient. There is a large full thickness macular hole with mean hole diameter is 799 micron in the OCT. Here is the OCT picture. I started the case routinely and PVD was induced, vitrectomy was completed. But in the when I inject the dye, there is a sudden blowout of the cornea, and this type of situation can occur in case of post PKP patient. And I just repose the iris and suture the cornea with intermittent on and off of the fluid, and not forget to tuck all the sutures. Then the situation is under my control, and then I peel the ILM. My motto is to do an inverted flap technique, and after fluid gas exchange, my case is closed, and there is a type 1 closure, and after 4 weeks post of the visual acuity was 6/16. Thank you so much.
Thank you, Shobik, for a nice depiction of your complications. Dr. Reddy, please.
Yeah, the case that in which you showed is developed a brown mound
Choroidal.
while choroidal mound. If it is choroidal detachment, how come it settled so quickly after?
It is a vitrectomized eye first. So, my scleral rigidity was less that time, and there is an accidental slippage of the infusion line, and that's why the fluid actually goes inside. When I remove the cannula and trocar itself, and using the rising the intraocular pressure, the fluid gets inserted.
I think basically it was eye because extremely soft the globe collapse and may not be exactly scleral choroidal detachment. Because once a choroidal detachment happens, I mean it doesn't spontaneously settle down once you change the infusion cannula.
Actually,
to
I
the
have
opposite
seen
quadrant.
such cases of my mentor, Dr. Boral, and there is a kissing choroidals, and
Sclerotomy was angled and they are self-sealing, it will not drain the choroidal detachment.
Yeah.
But if his sclerotomies were perpendicular, once he removed the cannula, it might have drained the choroidal. Only thing which was different was it was in superior quadrant and
Good quadrant.
cannula was coming out in
In the inferior temporal.
normally it
So
comes in that
basically,
quadrant only where
that case may be extreme hypotony that has caused the
choroidal
folds, not exactly a detachment maybe. So
if it was suprachoroidal, it was looking like hemorrhagic choroidal detachment. You were really lucky.
Yes.
Because superiorly this kind of mound, if you see away from the infusion cannula, by first
see, choroidal detachment, they don't resolve so fast. and
Similar
elite-
kind
and
of
they don't drain
situation
so
I will
easily.
showcase in my presentation. Similar kind of situation. Just to see, it was.
Excellent presentation. Dr.
thank you, sir.
You can use the mic.
Okay.
use two forceps to reposit the retina when retina curves back on a posterior plane.
Okay.
Keep it there for some time, then it sticks. Otherwise, it keeps falling back.
Actually, I didn't go for 360 retinectomy, and that kind of traction.
Because at that stage he was under air. It was under air.
Yeah.
He had to make the infusion on again. Then only you can just repose it. Otherwise,
Switch on the infusion.
if you do the yes.
Okay.
And you just make the relaxing incisions on the sides. And then pull with two forceps, with chandelier. Keep it there for some time, it's stuck.
Okay.
Otherwise, it keeps coming back.
Okay, sir. Thank you for your suggestion.
Thank you, Deepander. So I'm sharing my
Case 1. A repaired cornea.
yes.
and a large written intraocular foreign body just beyond the posterior exit wound, trapped in the sclera at the inferior macula. Oh my God, a daunting task was ahead of me. Vitrectomy was performed. An attempt to release one pole of the trapped foreign body with a bent 24 gauge needle tip failed. The foreign body went vertical, then aligned itself horizontally and got trapped in the sclera. Use of 20 gauge foreign body holding forceps and magnet after converting one port to 20 gauge also failed. Now what else is left? Then came the lightning flash to the surgeon. Radial releasing incisions in sclera. Multiple radial releasing scleral necks were made using 23 gauge MVR blade.
It was almost an impossible kind of situation for me to took out the partially exposed ROFB.
The retained intraocular foreign body was bimanually manipulated with bent tip 24 gauge needle and magnet and made intravitreal. It was then removed through the limbal section. PFCL removed, laser done around the break after a complete fluid air exchange, and silicone oil injected. Post-operatively, retina was on. 5 months later, final visual outcome of the patient was
After silicone removal and glued oil implantation, patient finally gained 6/9 vision. Thank you. So this was my first complication, first longest day. My second longest day is what Dr. Shovik showed, that sudden intraoperative kissing choroidals that arise from during my routine VR surgery. It was a case of retinal detachment with choroidal detachment and with a lot of hypotony. So I have injected just before injection, just before surgery, I have injected BSS intravitreally to raise the IOP and checked all the infusion port and all the other ports, whether it is intravitreal or not, and then started the surgery, did vitrectomy, and there was a tear in the infratemporal quadrant, and injected PFCL and did vitreous base excision, everything, all the routine procedures, and finally at the end of surgery I was doing the fluid exchange and did laser, and the only thing left for me, it was just to inject the silicone oil. I was waiting for that. I just removed all the instrument and asked the assistant to give me the VFC syringe and just see. Nothing is visible. When I went inside, nothing is visible. Now you just see the absolutely kissing choroidals retrolental. And then what next? What should I do? Basically, I was not very much perplexed state of mind, because it was a unique complication happened to my. And I saw that infusion was in partial fluid exchange state and it was partially withdrawn, so I removed it. I was pretty sure that my supratemporal quadrants and supranasal quadrant was is totally absolutely okay inside the vitreous cavity. Just see if I repeat the situation like this, you can see the choroidals just vanished, just vanished even just after introduction of this infusion port in air fluid exchange state. Then I introduced my trocar cannula inside the suprachoroidal space. I was thinking that it might be the suprachoroidal air entry, and just removed all the air after raising the IOP, and then introduced my routine trocar blade from another side, 40 minutes away from the limbus, and checked the infusion port. It is inside the vitreous cavity. then rest of the fluid has been removed and injected silicone oil. So I was fortunate enough to get rid of this kind of devastating nightmare. Thank you. And my third complication, it was a very unique situation. Although the final outcome was not gone well, it was a repair. It was a like post firecracker injury, and a lot of hyphema was there. Primary anterior segment surgeon removed the hyphema first. Then I did lensectomy from the anterior approach. Then gone inside to remove all the residual lens matter and the vitreous exudate. It was quite dense, and I was not getting any plane to separate all the exudates from the surrounding retina, and you can see just some unusual particles are coming out, and it was a case of firecracker injury, and I was thinking about the sulfur granules or the iron particles, all these things, but the foreign bodies were not like that. I had a question, what could be the foreign body, nature of the foreign, because we have not sent it for the identification purpose. Like you can see the granules, it's just like mercury foreign body, but it's not mercury. I've gone through the literature that firecracker injury, mercury foreign body is not there. It's mostly there sulfur granules and aluminum particles and sodium and other copper also, but mercury particles are not there. My presumptive diagnosis might be their aluminum particles, so I just tried to remove the exudate from the underlying detached retina. It was already retina detachment was there preoperatively, and finally I removed the exudate as much as possible. It's not totally 100% gone, but still. And but the particles, the glistening particles were quite abundant, especially in the inferior half. And you can see the particles were quite studded overlying the retina as well as the within the exudate itself. You can see the silvery colored glistening particles. So my assumption, they are intraocular aluminum foreign body. They can cause very purulent kind of inflammation. Hardly we can, and preoperatively also aluminum is hardly you can see, because the bone density index of the aluminum is very low. You cannot separate the particles from the bones. So, and intraocular, just see the eyelash, I have removed it. Very bad kind of situation, and finally I could able to settle the retina and injected silicone oil. Patient's vision was PR inaccurate, preoperatively and postoperatively also. He couldn't save the eye. So because of this purulent fulminant inflammation, it is very difficult to save those eyes. Otherwise, you have to remove the, you have to eviscerate this kind of eyes. So another thing, like if time permits, that basically in submacular hemorrhage, it's very you should be very cautious to avoid the intraocular. During surgery, you have to remove the, you have to be cautious regarding your intraoperative macular hole formation. In my initial stage, during the injection of subretinal TPA and AR injection, in one of my cases that I wrongly injected the subretinal TPA inside the macula, not outside the macula, and just see there is sudden egress of fluid coming out from the macula fovea, because the fovea is the thinnest part of the macula, and easily foveal blowout can occur during the surgeries. I just did a little bit of drying to dry that iatrogenic macular formation, and did fluid exchange, SFC's gas injection, advised the patient to do strict prone positioning, and postoperatively I was fortunate enough that macula was actually closed, and patient vision finally improved to 6/18 vision. But I was fortunate in this case, but not always you are fortunate enough, because in my another case of old submacular hemorrhage, when I injected retinal TPA, and finally I ended up like with postoperative macular formation. Now I have to reoperate the patient again. So what is the procedure should I do? So I plan for some kind of minimalistic approach, because less you do, less complication you you will create. That is my philosophy. More you do, more complication you can face. So I just strained the ILM and try to do the inverted flap technique, but not all around the macular hole. Just I peeled one flap from the temporal side, just like Dr. Zofia. Ideally, initially he proposed that from the temporal side, just opposite the flap over the macular hole. That's all. And nowadays we all do the ILM pinning around the macular hole, but in this case, I just peeled the ILM from the macular hole side. Then started doing fluid exchange again. I was not pretty sure that whether macular hole should close or not, but my gut feelings was saying macular hole should be closed, and finally it closed. So these are the things. The interpretive complication or something unusual. So my question to the audience as well as our esteemed co-speakers, what could be that foreign body in my third case? Is it aluminium foreign body or something else? What is your opinion? Ha. Ha.
Basically,
They come in so many different forms and shapes.
And it contains all kinds of dust and also.
Had to be sent to the lab.
Yes. That was gone with the cutter, not with the forceps. So in my I have to filtrate it from the cassette fluid. That was the
Dr. Subhendu, the first
Yes.
case that you did a large foreign body,
yes.
you could also try to remove it from the outside, see outside conjunctiva and send whether it is more easier to remove
Yeah,
it from
basically
outside.
there was a lot of vitreous evidence, so I couldn't think if it is gone from the outside. That means the part of the foreign body was inside the vitreous cavity. It was exposed, and most of the part it was outside the foreign body,
Yeah, yeah.
and outside the. But
Outside.
in the CT scan, it was showing that it is inside the ocular coat, or in ultrasonography, it is within the vitreous cavity. But it might be due to the clot in the ultrasonography, or maybe it is the foreign body, which is very difficult. It's quite posterior,
So
quite
we had-
posterior. So if you can do such a posterior placed magnetic, yes.
I mean, if you bredel all the
I-
sutures and try to see,
I tried with the magnet, but it failed because it's just strapped. It's gone inside, then horizontally, then gone vertically. So it's very difficult to. Yes.
I think you'll change your mind once you look from outside. It's easier to remove it from outside. If you
Yes.
Have a look.
But it was such a posteriorly
bredel all the
placed.
sutures and then see outside. And
You
it's
could have
easier.
injured the optic nerve. All these complications. So
The next
thank you,
session, people
thanks
waiting
to
here.
all the audience for attending our session. Hope next year we'll come with newer complications. Thank you. Long live retina surgery. It should not be robotic. We should not leave our retina surgery into the robots, hands of the robots. চলো একটা group photo.
কত সই সবার